Howdy, y'all. Just as a heads up, a couple slides in this lecture have some strobe-like animations. So if you're sensitive to these, avoid watching this video and send me an email or text so I can get you these slides in an alternative format. Welcome back to our second vascular ultrasound lesson, where we're going to focus on Doppler ultrasonography. While we've touched on some of the uses of Doppler modalities in previous lessons, we're going to explain some of the physics that will help us understand just how useful Doppler ultrasound can be in the clinical context. We are also going to go over the different types or modes of Doppler available to us and see how each one is uniquely suited to answering different clinical questions. And just for fun, one of the extra benefits of this lesson is that if you pay attention, you may learn some ways to argue your way out of some speeding tickets using physics, but I claim no liability if it doesn't work out in your favor. Let's get started. It should be reviewed by now, but remember that the Doppler effect refers to the way a frequency reflected by a moving object is perceived to change relative to the observer. This is the concept behind not only medical ultrasound, but also telescopes that image distant stars and galaxies, radar guns used by law enforcement to catch speeding vehicles, and even echolocation used by organisms such as bats and whales. Also remember that by convention in medical ultrasonography, flows that are moving towards the ultrasound probe result in the perception of frequencies being shortened, and that these are assigned the color red on color Doppler. We will also use numerical values of these shifts to calculate velocities of blood movement. And when the blood is moving towards the probe, we assign these velocities positive values. Conversely, flows that are moving away from the probe result in Doppler shifts that appear to be lengthened and are categorically assigned negative velocities and blue on color representations. I'm going to flesh out a term which I introduced in our last lecture, the Doppler angle. Recall that this describes the angle at which our ultrasound beam intersects the vector of flow in a vessel. So we know that if we fan our probe broadly to image, for example, our carotid artery, that when our probe is pointed more caudally towards the heart, and thus towards the origin of our blood flow in that particular vessel, the color we'd see on our display would be red on color Doppler. And then if we change the direction of our probe, still imaging the carotid, but instead aiming our ultrasound beam more cranially, that now that blood that's moving away from the probe as it courses would be blue and ascribed a negative velocity. But what do you think would happen if we were to position our probe directly perpendicular to the artery? Well, if the ultrasound beam would hit the vessel and not be able to determine if any flow was present because there was no Doppler shifts that would be able to be measured. While the specific trigonometry behind this isn't something I expect you to learn, I do want you to be familiar with the concept that the closer that the ultrasound beam is to measuring the flow in a vessel head-on, the better our measurements will be, and the more precise our calculations. In an ideal world, this would mean we should always try to point our probe directly at oncoming or outgoing blood. Now, this is rarely possible because our blood tends to move in vessels that run more or less parallel to our skin, and we also need to work around things like bones or organs or clothing or bandages or wounds and all the other things that prevent us from getting that optimal view. Because of this, our machines can help us correct for the amount of angle with which we're intersecting the blood flow we want to measure. And this is termed the Doppler angle. The lower this value, and specifically when the Doppler angle is less than 60, the more accurate our measurements will be. And this is a number we can manipulate on our probe position and by using settings on our machine. Now, if you've used Doppler technology before, you may have noticed several different modes of Doppler being referenced. And sure enough, if you look at our machines in clinic or at the hospital, there are a variety of different buttons you can press that use Doppler ultrasound to generate images and data for us as we scan. Broadly speaking, we can group these descriptions of Doppler modes into two groups. The first is describing how we're collecting or sampling flow. The second describes how that information, whatever we receive back from our scan, is displayed and interpreted on our machine screen in calculations. We're going to run through each of these modalities and explain them, with attention being paid to the pros and cons of each mode, so you can decide which to use when answering a clinical question. The first of our two sampling methods, and the one more commonly used, is called pulsed wave Doppler. Pulse wave Doppler operates like a sonar system, or like a bat echolocating. It sends out short bursts of the signal at regular intervals. But in between those transmissions, it's not emitting any signal at all, and instead is listening for returning echoes. When echoes return to the transducer, the machine can thus calculate both the Doppler shift, but also measure how long it takes for those echoes to return, which gives us a depth measurement as well. Because it allows us to display this information over a B-mode image, we can choose a display mode like color flow and identify vessels and the direction of flow within them. The trade-off of plotting the depth or the location about these Doppler shifts is that we sacrifice a bit of information about the velocity being measured, particularly in vessels or organs with really high flow rates. This is due to something called the pulse repetition period and Nyquist limit, which, though it sounds like the name of a groovy funk band, is actually a limiting factor that we'll discuss in a couple of slides. If you're more of a visual learner, here's a graphical representation of pulsed wave Doppler. So we can see that short bursts of transmission are being released from the ultrasound probe, but that there's a window between each of those bursts where the machine is basically listening for the echoes to return. The time it takes for an echo to return can be calculated as a depth, and thus we get rich information about the location of any of those measured Doppler shifts. In contrast, our other option for sampling method is called continuous wave Doppler. And as its name suggests, continuous wave Doppler modes are constantly sending a continuous signal of a specific frequency into the tissues, while a second element of the transducer is constantly listening. The most common applications of this technology in the medical field is in the handheld Dopplers that we use to listen for fetal heart tones or peripheral pulses when we're evaluating for blood flow in the distal extremities. Outside of medicine, this is also the method used by radar guns that measure speeding vehicles, as I alluded to at the beginning of the lesson. The advantage of a continuous wave Doppler is that because a very specific frequency is being emitted by the probe, we can get very specific Doppler shifts back and thus have extremely accurate velocity measurements. We can also measure flow rates that are really high, that would typically exceed the ability of pulsed wave Doppler to detect. Now, the downside of this is that because we're constantly sending out a frequency and constantly listening, we don't really have any way of knowing where along the ultrasound beam those echoes are being generated. It could be quite close to the transducer and so superficial in the body, or it could be coming from a deeper vessel along that same path, and we have no good way of knowing. So we can't calculate a depth, and thus we can't map that velocity to a particular location. So if you get pulled over for speeding by a cop who's using a continuous wave Doppler technology, the speed that they measured is likely accurate. But you can tell them that due to the inability of continuous wave Doppler to measure time of echo return, it's impossible to prove that your vehicle was actually the source of the returning Doppler shift. Now, if you try this out, let me know how it works for you, and remember that I'm not responsible for any tickets you do end up getting. Again, for our visual learners, this graphically represents continuous wave Doppler, where one crystal of our transducer is continuously emitting a frequency, and the other is constantly listening for returning echoes along the same line. So, now that we've talked about our two methods of getting information back to the machine, how do we display or interpret that information? Well, the answer is a broad category of modalities called duplex ultrasonography. The term duplex refers to the simultaneous use of our 2D or B-mode grayscale ultrasound image and then superimposing the Doppler shift data onto that B-mode image. So again, for our visual learners, duplex ultrasound takes our standard B-mode image while at the same time sending a Doppler frequency into our tissue and receiving echoes that contain Doppler shift information. It then superimposes that data onto our B-mode image with colors or sounds or other changes that we can use to answer a clinical question. Let's go over three of the most common forms of duplex ultrasound that are used in point-of-care settings. In general, duplex ultrasound can be used to display the location of flow, and is thus helpful for identifying vessels that are either the targets of cannulization, like central lines or IV access, or that should be avoided when performing other procedures with needles or medical instruments. Color flow is probably the most commonly used Doppler mode in point-of-care applications. Color flow maps flow patterns by using measured Doppler shifts and displaying those as various shades of red or blue pixels corresponding to the size of the shift measured. Color flow will prioritize information about the direction of flow and displays this data by averaging Doppler shifts over a wide sample field. So some information about low flow or small vessels is going to be lost as a trade-off. However, this is still the most commonly used form of duplex Doppler imaging in my practice and is almost uniformly used when performing ultrasound-guided procedures. Power Doppler interface is similar to color flow in that it projects colored pixels onto our B-mode image. However, the directionality of flow is not displayed. So all flow that's measured is displayed as red and yellow pixels based on the magnitude of flow, regardless of whether it's moving towards or away from the probe. Because we've prioritized detection of flow rather than the calculation of direction, we're able to utilize this modality to identify low flows that might be missed by color Doppler. I use this modality when performing exams that are specifically looking for the presence or absence of blood flow, such as if I'm evaluating for torsion, and when I'm trying to identify small or low flow vessels, or sometimes when my exam is limited due to anatomy or positioning that prevents an optimal Doppler angle, as this method is a bit more forgiving and still shows me if a vessel is present that I might otherwise not know about if solely relying on color flow. The last modality that I'll mention is the most complex, but also gives us extremely rich data from which we can draw conclusions about our patient. This modality is called spectral Doppler and refers to the generation of a graph of frequency shifts displayed over time, with the magnitude of the shifts being plotted along the y-axis, time along the x-axis, and the brightness of pixels, which can be considered the z-axis, representing the number of times that frequency is being measured. Or, as one of my mentors put it, the frequency of the frequencies. This is the way sonographers measure flow patterns when assessing for stenosis or occlusion, when calculating advanced cardiac metrics, or when evaluating peripheral arteries. You may hear this modality referred to as triplex ultrasound, but it's falling out of fashion to some degree. Chances are, if you've had previous experience with POCUS, you may be familiar already with color flow and power Doppler. However, it's less common for residents and medical students who I work with to have a familiarity with spectral Doppler. So we're going to take a deeper dive into spectral Doppler and its many uses over the rest of this lecture and the following. Let's start out by understanding how we get a good quality spectral Doppler display. Before we activate the spectral Doppler mode, we should use the machine to find our standard B-mode 2D image and manipulate the probe, image, and gain to get our target vessel in view. When we activate spectral Doppler, a field of color flow Doppler signals will be placed onto our image, along with a single line that corresponds to our ultrasound beam that will be used to select where exactly along that line we want to sample our data that is eventually going to be displayed as our spectral waveform. We will then adjust our machine settings to optimize our image, and then use the roller ball or the dials on the machine to place this line, and most importantly, the little gate of this line, over the area we wish to sample. If the gate is not over the vessel, no flow will be detected, and thus no spectral waveform would be displayed. Next, we will use one of the knobs on the machine to correct the angle of our gate to be oriented along the long axis of the vessel. This is essentially providing the machine with information about the Doppler angle, which as a reminder is the angle of intersection between the incoming ultrasound beam and the flow of the vessel, which we want to be ideally as acute of an angle as possible, with a maximum angle of 60 degrees. By using our angle correction adjustment, the machine will know the Doppler angle and the trigonometric calculations will be accurate. So with all of this information, finally a spectral waveform will be generated. This waveform will be displayed as a wave with a zero flow baseline displayed horizontally as the x-axis. Flow towards the probe will be plotted above this line as positive velocities, and flows away from this probe will be plotted below the zero line as negative velocities. If this is confusing to you, hold that thought for just a minute, because my hope is that this will become clear in a few seconds. So this is the basic spectral Doppler schematic that I've drawn for you. We see a baseline flow that's positive, meaning forward flow towards the probe, and peaks that correspond to systolic surges, along with valleys that represent the diastolic flow period. While it would be nice if all of our spectral Doppler waveforms were this nice and neat, we know that's not going to be the case. The schematic I drew on the previous slide assumes that all the blood was traveling at exactly the same speed and direction. That is, that all of the velocities were the same. However, we know that blood flow is not perfectly laminar, and that even in a cross-section of a single vessel, the flow rates will vary. Let's look at that one more time. Recall that blood cells located in the center of the lumen tend to travel faster than those closer to the periphery. While not technically accurate, I like to think of this as being sort of similar to friction, where the interactions of cells along the margins of the vessel are slowed down by those interactions. So if we look at our Doppler gate up here in the right corner, we see that the sample area is not a single point, but rather a small cross-section of the vessel, and that within that gate there will be a variety of cells, all with similar but non-identical velocities. So if we were to measure the Doppler shifts in this area, this whole gate, we would see a pattern of change that follows systole and diastole in the cardiac cycle, but there wouldn't just be one frequency, it would actually be a range of frequencies detected. And so instead of plotting a single line, we'd actually get something a little bit fuzzier. If we plotted those frequencies out, we can see that we have still the pattern we had previously, but that now there's a range of frequencies being recorded, and thus a range of velocities, with each returning echo representing one data point out of thousands or millions of data points. Each pixel on our screen represents a Doppler shift, and the brighter the pixel, the more frequently that shift is being measured. All of these pixels are plotted together, and in aggregate, give us this fuzzy waveform. This illustration I made is a crude representation of this concept, but for our purposes, it should suffice to help us remember that while we can think of the waveform as a single line, following this nice pattern where the pixels are the brightest, the reason we actually don't get a single line and instead get this staticky or fuzzy display is due to the variability in the velocities being slightly different from cell to cell. Let's add some further complexity. So we know that when flow through a vessel is disrupted or altered due to kinks, thrombi, or atherosclerosis, the blood travels abnormally fast and creates areas of turbulence, which affects the ranges of frequencies or velocities we will pick up. There will also be some areas where the flow is less fast, it's slower, and these little eddies form and the overall velocity drops. So what does that do to our Doppler waveform? Well, let's use this as an example. If this vessel had a partially occluding plaque that disrupted the blood flow, the peak measurements we would see would be faster, and there would also be a more widely distributed velocity measurement. When we plot these areas as a spectral Doppler waveform, it results in a couple of things. First, we see a filling in of the area underneath the wave. So we see that all of the space underneath the waveform is actually taken up. Additionally, we can see that for some reason on this graph, there seems to be some velocities that are being displayed in the negative range, and those are corresponding with the peaks of velocities above them in the positive range. And this is an example of an artifact called aliasing, and we're going to understand why this happens by reviewing the concept of pulsed wave Doppler. As a reminder, we are usually using a sampling method called pulsed wave Doppler, which has discrete transmitting and listening periods. I mentioned that one of the drawbacks of pulsed wave sampling is that it has trouble measuring high velocities. And the reason for this is because of its non-continuous periods of listening or receiving echoes, which gets messed up, for lack of a better term, when the echoes are actually returning faster than the machine is listening. When this happens, it results in the aliasing artifact that we saw on the previous slide. To understand why aliasing occurs, let's talk briefly about some physical properties of pulsed wave Doppler. We know that pulsed wave Doppler has a cyclical period of emission and listening that repeats over and over and over again to create ultrasound waves and detect the echoes they generate. The rate at which we generate these emissions and echoes is known as our pulse repetition frequency. We can refer to the length of time it takes for one cycle of emission and listening as the pulse repetition period. Now, the terms pulse repetition frequency and pulse repetition period actually refer to inversions of each other, but sometimes you'll see people conflating those two things. The pulse repetition frequency is measured in hertz, and the pulse repetition period is measured in units of time. Now, to be able to measure a Doppler shift accurately, the velocity of the returning echoes needs to be sufficiently low that two such echoes are heard in one listening period. This is kind of hard to explain, but I've got a couple of GIFs over here on the right that are animated that might help you wrap your mind around it. The way I think about it is, have you ever watched a fan or a propeller engine start after being still and watched as those blades sped up and up and up and rotated faster and faster? Well, you may have noticed that at a certain point, it appears that the blades actually start moving backwards. This effect is also seen on wheels, on cars, like especially if you watch an older movie where the wheels will seem to be spinning backwards despite the car moving forwards down the street. And this is due to an optical illusion that's caused by the frame rate of our cameras, or in real life, the frame rate of our eyes, to detect the speed at which these things are rotating. Take a look at these wheels that are animated on the right. Each time that the frame on the left flashes, a frame is being displayed on the right. And when we watch these sequentially, we see that the top wheel appears to be spinning in the correct direction, but because the bottom wheel is rotating at a speed faster than half of the frame rate, the wheel on the right appears to be spinning backwards, even though it's actually spinning quickly. Now, we can think of the frame rate of our ultrasound machine as being the pulse repetition frequency, because each time we send out a pulse and get an echo back is analogous to one camera frame or one data point being captured. The limit at which we can no longer differentiate forward from backwards motion, well, that's half of our pulse repetition frequency, and that's called the Nyquist limit. When Doppler shifts above the Nyquist limit are encountered by the machine, it will assign them negative values, and this results in the artifact known as aliasing. This is a complex topic, so I'm going to repeat what I just said. The limit at which we can't differentiate forward and backwards flow is defined as the Nyquist limit. When Doppler shifts above the Nyquist limit are encountered by the machine, it will assign them both positive and negative values, which results in this artifact known as aliasing. When using color flow, this will result in both red and blue shades of pixels being displayed in a single vessel, like you can see over here on the right. Similarly, if we use spectral Doppler, this will show both positive and negative velocities being displayed with the same time, and it sort of looks like it's wrapping around the x-axis, as you can see on this image. So how can we prevent or fix aliasing artifact? It all boils down to changing the machine settings so that our sampling rate is higher. If our sampling rate is related to our pulse repetition frequency, we need to find ways in which we can increase the pulse repetition frequency and thus send out more pulses per second. The first way we can do this is by decreasing the frequency of the probe we're using, either by shifting probes to a lower frequency or manually lowering the frequency being emitted by the probe using a knob on our machine. This seems kind of counterintuitive, but when we lower the frequency of the pulses we're emitting, we also lower the frequencies of the Doppler shifts that are coming back, which widens our ability to detect them. The next way we can reduce aliasing is by decreasing the depth of our B-mode image. By doing so, we're shortening the amount of time it takes for sound waves to traverse the area being displayed on the screen. When less depth is being sampled, we can send more pulses per second because we don't have to wait as long for those echoes to return. They're going more superficially into the tissues. Thus, our sampling rate will increase, which increases our Nyquist limit. And lastly, we have some control over the scale at which the data is being displayed. The machine is adaptable to accommodate low flows in the IVC and peripheral veins, as well as high flows of cardiac and arterial regions. So sometimes just adjusting the scale manually will resolve the aliasing. However, the limits the machine sets on the scale are determined by the physics of the frequency, pulse repetition period, depth, and other settings. So you can't just rely on the scale in turning the knob of the scale to solve all of our issues. The last thing I mentioned is that for extremely high velocities, like those that we might see inside the heart, we may turn to continuous wave Doppler to measure these. In those circumstances, we know that the highest velocity, the highest rate of flow, is going to be in the area that we're measuring, even if we don't accurately pick it on the screen. As long as our cursor is going right over the valve, that's going to be where the highest flow is. And so it's not as important for us to be able to measure where that flow is occurring. We're really wanting to know exactly how fast that flow is occurring. So when we lose the ability to pinpoint where along the beam those velocities are coming from, sometimes applications for this are limited. But because there's no Nyquist limit, because we're constantly sending out signals and constantly listening, there's thus no real limit to the velocity we can detect. These two images are not of the same patient, but for the sake of our learning, let's pretend that they are. On the left, note that our color Doppler display shows a colorful mixture of reds and blues. And this is what aliasing looks like on color Doppler display. And below it, we see the spectral Doppler waveform that looks like it's wrapping around with the signal from the top of the display moving to the bottom, consistent with aliasing. Now on the right, we can see that this flow is now resolved on an appropriate scale, either by lowering the probe frequency or using a lower frequency probe, or adjusting the machine scale to prevent aliasing and wraparound. If you somehow managed to avoid your brain melting from all the technical mumbo-jumbo, kudos to you. If you're feeling a bit whiplashed, that's totally normal. With time, I promise these concepts will become more accessible. Spectral Doppler has many uses, but some of the ones that are most relevant to point-of-care applications include those listed here. By comparing flow rates and spectral patterns to known standards, we can identify vessel occlusion in conditions like carotid stenosis or peripheral vascular disease. We can use spectral Doppler to calculate a flow rate across cardiac valves and calculate peak systolic pressures or the cardiac output. And we can use spectral Doppler to monitor vascular resistance patterns in conditions such as chronic kidney disease or fetal growth restriction that might impact our management of such patients. The next lecture will focus on the interpretation of spectral Doppler. It's going to be a doozy, but if you feel confused at first, don't fret. We'll get through it together, and as always, I'm here to help and answer any questions that come up along the way.